Please make it full screen.
Is it now?
Yes, yes.
Thank you. So at the outset, I thanks our president and chairman and organizing secretary and scientific committee chairman for giving me this opportunity. And in Bihar today is a Chhath, so happy Chhath to all of you. So topic given to me is a very important topic, managing infection, specific to diabetes mellitus. So infection and diabetes mellitus is the two key words here. But when we are talking about infection and diabetes, there is a lot of additional keywords which I have mentioned here. And we can, as we follow the presentation, you can see how things has worsened when diabetes and infections are there. When the topic first word is the infection. So we want to know what is the condition of infection in our country. And there is no conflict of interest in this presentation from me for this presentation. So this is a ICMR. Menon presented this in the Lancet 2019, that India National Burden of Estimated Health Life Lost in India 2017. And in 2017, what was there? 9.7 million death and 486 million disability adjusted life year in India was there. And this is more due to nutritional condition, chronic respiratory disease, diarrhea, and fever of unknown origin. So this is very important that India is already overburdened with the infectious disease, whether it is a male, female, both urban, rural, across the India is overburdened. Same way, when we have prevalence of diabetes in 15 states of India and ICMR 2017, they have found that India having 11.2% urban population have diabetes. And this is a very big study. And we are talking about 11.2% of urban population with 133 million people, then it's a huge number. So we have a very big number of diabetic and very overloaded infectious disease. So if both are combined and then see the mortality, so this is a Dr. Jerger paper in 2009 and cause of mortality in diabetes and data from the tertiary care teaching hospital. And they have found that diabetes is in diabetic infection in type 1, type 2 or combined infection is the first cause of mortality as compared to our Western counterpart, where the cardiovascular and cerebrovascular disease dominates this chart. So when we are talking about diabetes and infection, infectious disease is important yet often neglected corollary of the uncontrolled diabetes mellitus. In the pre-insulin era, most death of type 2 and type 1 diabetes occurs as a result of uncontrolled infection due to hyperglycemia. Longer duration of diabetes and poor glycemic control cause 25 to 75% increase in the relative risk of infection in diabetes. And in the COVID-19, even the new onset of diabetes has been seen, and we'll see in the later slides. So what happens to diabetic and hyperglycemia? The hyperglycemia and susceptibility to infection, the ADA has said that infections are the important issue of individual with diabetes due to immune system failure. And the immune system failed, and that the failure to fight the invading pathogen due to the complement is in the immune system decrease, cytokine without stimulation increase, cytokine after stimulation decrease, adherence increases in the human immune system. In the cellular immune system, polymorph leukocyte, monocyte, macrophages, and T lymphocyte all decrease. So this makes very high susceptible individual of diabetic to have infection. And not only the immune, even when anybody is having diabetes, there's a low secretion of the inflammatory cytokine, glycosuria, GI dysmobility, hyperglycemia leads to virulence of the microorganism and apoptosis of the PNM, large number of medical intervention, neuropathy, angiopathy, antioxidant system depression, disorder of the humoral immunity, neutrophil function decrease, T lymphocyte, all these mechanisms makes diabetic for prone to have infection. So now, is the only diabetic making infection more prone, or the infections also have some role? So here is the paper by Dr. Anup Mishra, and that is the relation of diabetes and infection has been known for long and is traditionally considered as a bidirectional. It is not that diabetes only have this, even the infections also is stress response, poor diet, inadequate, insufficient therapy, and hyperglycemia makes the infection to for hyperglycemia, and this vicious cycle with the risk factor with the diabetes has become more prone to have infection. So infections also cause hyperglycemia, and hyperglycemia also prone to have infection. So this vicious cycles goes, and this as proved in the new onset of COVID-19, there is a bidirectional relation of between COVID-19 and diabetes. On the one hand, diabetes is associated with the increased risk of severe COVID-19. And on the other hand, new onset diabetes and severe metabolic complication of pre-existing diabetes, including diabetic ketoacidosis, hyperosmolar, for which the exceptional high dose of insulin are warranted when observing the patient with the COVID-19. So we see here when diabetics or the infection both going hand by hand, and that makes individual very sick. So what are the predisposing factors for the infection in diabetes? And this is the chapter written by Dr. B.K. Sahai sir in Medicine Update. We have already discussed the primary factors. In the secondary factors, the ketosis, use of intravenous acetylcholine, antibiotic misuse, overuse and resistance, frequent hospitalization, peripheral vascular disease, neuropathy, gastropathy, reflux, aspiration, indwelling urinary catheter, chronic renal failure and dialysis, and total parenteral nutrition. These are the secondary factors in which the diabetics has a more infection. Now, what are the classification of infection in diabetes? And see, the common infection which has increased in incidence in the diabetic patients are urinary tract infection, respiratory tract infection, soft tissue infection, and the infection predominantly occurs in diabetic patient is malignant otitis externa, rhinocerebral mucormycosis, necrotizing fasciitis, foreigners gangrene, inflammatous infections, inflammatous cholecystitis, inflammatous pyelonephritis, pyelitis, cystitis, and infection in the diabetic foot. So these are the infection which are predominantly occurs in the diabetic patient. Now, we want to know whether these are only in diabetics or whether they are compared with the non-diabetic, and the Diabetic Care 2018, where we have a relation of the type 1 and type 2 compared with the general population, and what they have found that they are increased relative risk for infection for bone, joint, sepsis, and cellulitis was there in the type 1 and type 2, 3.71 and 1.88 respectively. There is direct comparison between type 1 and type 2. In type 1, they have found more versus type 2, and estimated that 6% of infections relate hospitalization and 12% infections relate death are attributed only to diabetes. So this is very important that we control both. Now, this is the very vast to discuss each and every infections and what are the antibiotics. So for these are paper just 2007, you can download or take a screenshot. The skin infections having, you can diagnose with the wound swab culture. Depending on the culture sensitivity, you can start the first line or alternative therapy. If the therapy is not sufficient enough, you can go for the surgical. For the diabetic foot, the same way we have to follow. Necrotic fasciitis also same way we have to follow. Community acquired pneumonia, we do the chest X-ray or the sputum culture, or we need a blood culture or HRCT. And according to the mild, moderate severity, we need to adjust the antibiotic according to the need. In the urinary tract infection also, whether it is asymptomatic bacteremia, there is no symptom, there is no treatment required, but the hydration and the hygiene is very important. Cystitis, again, the same way, the urine microscopic and culture. Pyelonephritis, again, the culture and microscopic is treated. And according to the culture report, we have to give the antibiotic. Other necrotic otitis externa, rhinoceros mucormycosis, we need to do the more intensive investigation to find out what infection is there. And according to that, we have to give the antibiotic. And that if required, then we have to do a surgical intervention also. Now coming to we are in country with India, where we have a high number of tuberculosis patient and also the diabetic patient. And often we see that the diabetic patient have tuberculosis on oral hypoglycemic agent. But here the rifampicin is a potent hepatic enzymatic inducer. It accelerates the metabolism of several oral hypoglycemic agents, especially the sulfonylurea and bugenides, and lower their plasma level. So therefore, it causes hyperglycemia in diabetic patient, and in hyperglycemia, tuberculosis cannot be controlled or cured. So this is very important. When we are using rifampicin, we have to adjust the doses so to match the euglycemia. Same way in the isoniazid, it contrasts with the rifampicin, inhibit the metabolism of oral hypoglycemic agent, and may needs increase the plasma level of this drug. The main interaction with the sulfonylurea and the action of this antagonize and worsens the glycemic control in diabetic on this medication. It also impairs the release and action of insulin, leading to hyperglycemia even in the non-diabetic. So when we're using isoniazid, then again we have to adjust the dose. So therefore, the dose of insulin should be adjusted while adding and removing this drug from the patient prescription. Now, DPP-4 inhibitor, the new drugs, also have some reducing immunocomponent on the mechanism of action of DPP-4, and this affects the anti-tuberculous drug, and that dysglycemia will be there on these drugs, and then the sugars are not controlled, the ATT will not work adequately. So the oral hypoglycemic agents are contraindicated in severe tuberculosis, but may be used with caution once the disease is settled. And this paper was presented written by the Sanjay Kalra in 2012. So if we are having tuberculosis, the choice of medication is insulin. Now, why I said also, because in this rifampicin is an anti-tuberculous drug, which decreases the level of glyburide by 39%, glipizide by 22%, metformin, sitagliptin, glipizide, glimepiride, netaglinide, epaglinide, pioglitazone. So these all agents' plasma level is decreased in presence of rifampicin. So we have to adjust the dose. Not only that, sitagliptin and saxagliptin also studied here, and that also shows that plasma level of those drugs are decreased in presence of rifampicin. So it is better to have on insulin or with anti-tuberculous drug than the oral hypoglycemic agent. What are the general principles of diabetic during the intercurrent illness? The main aim to optimum glycemic control depending on the condition and comorbidities. Ensure patient take sufficient calorie intake, address the hydration with fluid replacement test, and manage if ketone present as per the protocol. Recognize whether patient required additional medical attention, means hospitalization or intensive care. When bacteremia and viral infections are there is present, blood glucose level may rise in response to the infection, even the food is not eaten. For this reason, during illness, people with diabetes must assess the blood glucose monitor, record their blood glucose level at least 4 times a day, at a meal time, and even they have not eating, and at a bedtime. Those do not have the blood glucose monitoring assessed, they should be educated about the hyper and hypoglycemic symptom. People with type 2 diabetes who do not manage their diabetes with the insulin should generally continue their medication as usual. If person is taking insulin, his blood sugar should be, if higher, then insulin dose to be increased. If it's low, then it has to be reduced. Ensure the sufficient calorie intake and address the hydration. As I have told earlier, the insulin a patient should eat normally. If it's not taking adequate food, then supplement with a liquid diet or semi-solid diet. They must address with the hydration, because in illness, dehydration is very common, and in diabetic, dehydration causes a lot of complication. So at least they should drink at least 2.5 to 3.5 sugar-free liquids per day, or 100 ml per hour to avoid the dehydration. However, if patient is not eating or drinking or start vomiting, it's better to patient shift to the hospital for IV hydration. Especially to type 1 diabetes, encourage adequate diet and fluid, which is already discussed. Encourage adequate diet fluid with vomiting, then we use antiemetic. We should assess the electrol and replace it. If however patient is not be able to swallow or keep fluid down for length or time or more than 4 hours, then we must shift the patient in the hospital for intensive care. Increase blood sugar monitoring at least 4 hourly. If moderate to large ketone are present, blood glucose station should be carried for 2 hours every 2 hourly. Ensure glucose and ketone monitoring equipment are accurate. Strips are dated as far as possible, and person self-testing techniques are accurate. Ketone testing should be carried out 4 hourly. If it present, then as per the DK or DKA protocol to be followed. Now coming to the insulin adjustment. Insulin should never be omitted. Despite the reduction of dietary intake, often both patient and healthcare providers have to convince that this is the appropriate course of action, because in infection, the insulin requirement increases. Increased insulin requirement often required during the period of illness and ill health. During illness, additional rapid-acting insulin administered 2 to 4 hourly to tackle the hyperglycemia. Basal bolus regime 4 injections per day is always better than twice daily premix insulin. Once the patient settled down, then we can restart the premix insulin as before. Coming to type 2 diabetes, same medication and hydration to be maintained. Patient has to continue. The main point is here, if patient is not taking oral fluid and not replacing the fluid intake, and patient is vomiting, then metformin, if patient is on metformin, should be advised to discontinue the metformin, because prolonged use of metformin and on vomiting and dehydration, it may cause lactic acidosis. So that time we can shift over to insulin regime basal bolus. Now, patients who is taking sulfonylurea, same way that we have used the insulin, same way the sulfonylurea also be monitored. We have to SMBG, we have to ask patient to do the SMBG to check their blood sugar with the hyper or hypoglycemia. Appropriate advice should be provided regarding the increased risk of hypoglycemia with the sulfonylurea if patient is not taking adequate oral intake. If it is not taking solid food, then asked to take some form of carbohydrate on the regular basis. Patient should be advised to contact their healthcare professionals if the blood sugar remain more than 300 persistently. Our patient should be admitted to the hospital for proper care. Patient taking insulin, again, same way, we have to check the sugar 4 hourly or before each meal and at bedtime, and adjust the dose with basal bolus. And basal bolus is always better than the premix insulin in acute condition. Now, patient on the insulin therapy, this already we have discussed, but often we have seen that in acute illness, patient himself omit the insulin, and this is very important. We must counsel that patient that you should not decrease the dose of insulin, but keep taking, check your blood sugar. If more than 300, ask the patient to admit in the hospital. Now, we are using a lot of new medications. The infection risk with the SGLT increases, and this is 2021 paper with the Donald has published. And these SGLTs are very noble drug. No doubt, it is a cardiovascular benefit, renal benefit, a lot of pleiotropic effects of the SGLT2s are there. But at the same time, the genital infections with the DANA, DAPA, IMPA, ITRO, IPRA, all are increased. So we have to judicious use of SGLT, and pragmatic use of SGLT require maintenance of the perennial hygiene to prevent. Okay, during any episode of avoid using patient with SGLT if there is a recurrent GIT that is more than 4 episodes per year, or history of recurrent GIT or upper urinary tract infection, then we should avoid SGLT. During episodes of UTI, temporarily discontinue SGLT, and once that over, we can restart. Required appropriate patient selection, medication counseling and monitoring is very important. Coming to the perennial hygiene, we have to educate the patient about the perennial hygiene to take preemptive measures for all diabetic patients receiving anti-diabetic therapy of SGLT. This should be include washing genitalia organ followed by urination or defecation, routine hygiene, wipe and spray. A woman should advise to wash from front to back. Uncircumcised male should be retract the penis and before wash and clean with the water, and mild soap is required, but avoid alcohol-based disinfection for washing. So this is very important when we are giving SGLT. Coming to the vaccine in diabetes, pneumococcal vaccination, pneumococcal polysaccharide, pneumococcal conjugate vaccine, these are the vaccines available and we are giving and using. Influenza vaccine, hepatitis B vaccine, and now the COVID-19 vaccine. For the COVID-19 vaccine, just 2021 March, Dr. Anup Mishra sir has published this paper. Patients with type 1 and type 2 diabetes are high risk for poor prognosis of COVID-19, and vaccination should be prioritized to them. However, many unresolved issues with the regard of COVID-19 vaccine need to be addressed to the future research. So at this moment, all diabetics should be take COVID-19 vaccine, but in future, we need to re-establish this guideline. There's a recommendation across the globe for vaccination. There is no dispute. And this Jyoti Dev Keshav Dev has published this paper. And in all the authority of diabetic has asked to take the vaccine. And these are the doses in United States 2019. And in India, all adult diabetic subjects should be educated about the administration of pneumococcal influenza vaccine who are aged above 60 years and should be strongly advised for vaccination. Children with diabetes more than 2 years should be given pneumococcal polysaccharide vaccine, and children above 6 years influenza vaccine. Other vaccine administered as per the need is required. Patient with a renal failure or immunocompromised state or on dialysis or with the obstetric or pulmonary disease, bronchial asthma should be taking all vaccines, and who are smokers also should be immunized. So if what we do get achieved is have a tight in glycemic control, maintaining tight glycemic control during pre and post-operative period associated with the lower incidence of surgical site infection in diabetes. And this is very important. If the sugars are controlled, the chances of infections are less. Maintaining tight control has been considered to be important diabetic foot also. And in a retrospective study of 7,300 patients in COVID-19 from China, what they have found that if the sugars are between 3.9 to 10 millimole per liter, the COVID is less motile than who have more than 10 millimole. So if the sugars are controlled in the COVID also, they are found to be a beneficial. So conclude, diabetes is a metabolic disease. Both innate immune response defect and dysfunctional adaptive immune response are throughout the possible for immune system weakness against the invading pathogen in diabetic subjects. So we need to control the sugar to better the immune response. Infectious disease continue to take a heavy toll of the population with diabetes even in the present day. The increased susceptibility of individuals with diabetes to infection has returned to a sharp focus with the advent of the COVID-19 pandemic, reiterating that need of achieving tight glycemic control and managing the comorbidities in this population from the time is diagnosis of diabetes is very important. There is a certain unusual infections are there exclusively in the diabetic patient, and we have to clinician dealing with the patient with diabetes should ever alert the possible of these infection. Prompt diagnosis may mean a difference between life and death in many cases. Immunization is the paramount in prevention. Cleaning and hygiene is vital. Awareness among the patient help their early detection. Without proper glycemic control, we cannot achieve anything. I appreciate all of your patience and time. Thank you, RCCI 2021, and long life to Trust State. Thank you so very much.